all the videos that we have, and you can check them out anytime you want. So yeah. So Zoom has started. I don't see anybody else on Instagram Live yet, but yeah, no problem. I can still give resources. I still care about educating people. I just want to make sure everyone's kind of got some resources to look at and continuing whatever they can do. Like, this is a tough time, but you can still work on rehab. You can still do some research and things like that. So just want to make sure everyone's getting, you know, a valuable experience. I had some dad jokes today, but I'm going to be the only one doing the presentation today. So yeah. So I don't know if it's frozen or not, but like, I think you're still the only one. There we go. We got some people joining it. There we go. Yes. And then I'm going to be a little bit all over the place today just because, well, not the whole day, but I'm the only one here today. So I got to make sure I'm checking Zoom and stuff like that. So is the background too bright for you guys, or should I do the blinds, or is that okay? Thumbs up if you want me to do the blinds, and thumbs down if you want me to not do the blinds. That's good. So today's going to be, we're presenting on knee pain, a very big topic. So I'll focus on a couple things, and then we can open it up to questions at any time. So I want to make sure that we get some things covered, and then with the knee topic, we can always go into topics for next week. So we can look into osteoarthritis. We can look into quite a few different things like ligamentous, ACL, MCL injuries, and things like that. So next week we can do a little bit more with the knee. And yeah, it's pretty much like an endless topic. So we can, and we're open to suggestions too. So if you want to shoot us an email or direct message us, I'd be open to suggestions. I always like hearing what people have to think and what their ideas are. So just make sure you let us know about what you want to know for the knee. I'm just waiting on a few more people on Instagram here. Usually there's more people. What the heck is going on? All right. Oh, we got Evan. Hello, Evan. How are you? How's it going? I could use some of your coffee right about now. I'm not getting good coffee, especially at the clinic. I cheap out on coffee, so. All right, so we'll give it a couple more minutes. We'll wait for more people to join. Yeah, I can read out some dad jokes for now. Hopefully this is funny. What's that Nevada city where all the dentists visit? Las Vegas. No, not too funny, but this was yesterday, so sorry for the repeat. Want to hear a joke about construction? Question mark. I'm still working on it. Yeah, that wasn't too funny. The favorite one of yesterday was, did you hear about the chameleon who couldn't change color? He had reptile dysfunction. How funny is that? No? What does Anju think? Let's unmute Anju. How's it going? No. Oh, not too bad. I thought I put you on the spot.
Yeah, you just did.
You got to get more people on this from U of A.
You're too busy.
You're too busy? Okay. And that deserves a mute. Boom. All right. So, yeah, that's some good jokes. Yeah. So knee, we're going to go through some basic anatomy of the knee. We're not going to get too complicated. We're going to do a discussion on PFPS, or patellofemoral pain syndrome. A very common thing people bring up. A lot of people have heard about it, and it's an umbrella term. So there's a lot of things within PFPS that we can talk about, but I consider it an umbrella term. You have PFPS, which pretty much just means knee pain, and then you have all these other, like, why is it happening? That's the biggest thing, right? Is it a muscular dysfunction? Is it a neuromuscular issue? What is actually the root cause of it? That's what we try to figure out as physiotherapists, and try to, mechanically what's going on. Is it a muscle that's too tight or a muscle that's too weak? We want to kind of do a detailed assessment and figure out what's going on. So rather than just telling people, hey, you have PFPS or patellofemoral pain syndrome, we want to do a little bit more and dig a bit deeper into it. So we'll be discussing some things, and some of this, well, a lot of it is evidence-based. So looking at a lot of literature, we're going to be talking about that a little bit, and kind of go from there. And then we'll open it up to questions as we go. And hopefully a few more people attend. I know there's a few people that are regular attenders. I'm going to open up an anatomy slide here. There we go. So I will grab this, and what we're going to do is we're going to point this the other way. So we have the knee joint. So we have the patellofemoral joint right here. Oh, sorry. I guess there's a poor connection. So yeah, if we get kicked out, I'll restart the video. And yesterday, I know there was a lot of issues, so we wanted to make sure that doesn't happen today. So if we do get booted out of this live feed, you can, and trust me that it's not me that has done it. I know Instagram's having a lot of volume these days. So yesterday there was a lot of issues with that. So without further ado, you have the knee joint. So you have the femur here, and then the tibia and fibula down here. So that makes the tibiofemoral joint. So the tibia and the femur articulating. So bending and straightening and things like that. So just like that. And then you have the patella here, the kneecap, and that forms the patellofemoral joint. So meaning the patella articulating with or interacting with the femur. So that is two joints right there, right? So you have, let's zoom out here. So you have the knee joint, right? So you have the patella here, you have the femur here, and then you have the tibia down there, right? So that's your knee joint. So it bends, so flexion, and straightens, extension. So you have the tibiofemoral joint right here that does that hinge type of motion, and then you also have the patella here that articulates with the femur. So yeah, so that's the knee. So you bend, you straighten. There's not many more motions that happen. The patella itself also does articulate, right? So as you flex, it moves one way. As you extend, it moves the other way. I just have to go into, sorry. I'm gonna stop the share here and let some people in. There we go. So welcome, guys. There's some more people on Zoom. So we're gonna go back to the knee slide here. So we're just discussing the knee joints. You have the femur, tibia, fibula, and the patella. So making up the patellofemoral joint and the tibiofemoral joints. So here you also have the meniscus here, which I'm sure a lot of people have heard injuries with that. Within this joint, you also have the ACL, MCL, and other structures like that too. So we're not going to be talking too much about that directly here. Yeah, and then you have patellofemoral pain. So bringing this next picture, so I like to think of it as patellofemoral pain just means pain anywhere in the knee. So you could have pain above or below the knee, deep to the knee, a lot of different areas that this can occur. That's why I call it an umbrella term. So it's definitely a difficult one to pinpoint because it can present like other injuries as well, right? So since it's very diverse in terms of what kind of symptoms you can have. Oh man. So it looks like, sorry guys, it looks like Instagram's having an issue. Give me 2 seconds. So yeah, it looks like live keeps having an issue. So, sorry guys. Looks like Instagram's having another issue. And now we're getting more people on Zoom. So looks like Instagram Live is having issues again today. It just keeps kicking us out after like 10, 15 minutes. So I don't know what's gonna happen with that. Sorry guys, on Instagram, looks like Live's not doing its job again. So yeah, we're gonna wait a couple of minutes for people to come on live. If not, I'll just continue going on Zoom. So whoever's on live right now, if you can go to our last post on Instagram or Facebook post, there is a link to our Zoom account. So you can actually just take a look on Zoom, which is probably a better idea. There we go. We got more people on Zoom today. Yeah, so we can continue as the Instagram gets loaded up again. Sorry if this is a bit fractured. I don't have anyone else here today, and I'm trying to deal with both platforms, and one that's not working very well. So, patellofemoral pain, meaning patella, femur, and pain. So you have, essentially just means pain in the kneecap area. And there's an issue with the patellofemoral joint, like we discussed, so where the patella meets the femur. So I'm gonna grab the Instagram peeps and show them the slide here. So that's what we're looking at. So now Zoom and Instagram can see what we're doing. So meaning pain anywhere in that kneecap area, and it can radiate a bit too. So yeah, that's kind of what I wanted to talk about for that, without making it too complex, because I know as physios we can make this as complex as we want. So I find a lot of people often ask like, well, I have pain in the knee, it's patellofemoral pain syndrome, and I want to strengthen, or I want to do this and that. So a lot of the times I say, well, why do you think you need to strengthen? What's the issue, right? So they might say, well, I feel weak in the knees, or I look at my posture and it's affected. And that's when we go through a lot of functional tests. So what I do as a physio, I'll get them to obviously do the range of motion and strength measures and things like that. But a lot of the times what I do is look at functional movement. So see them walk. Obviously we're taught a lot about ambulation. And then if their sport is running or jumping, I'll get them to do those motions. So I'll gradually progress to that, right? I'll get them to, so sorry, Instagram people that are coming back in, it keeps kicking us out again today. So check out our last post on Facebook or Instagram and go onto the Zoom link if you want to have uninterrupted access to this presentation. So it looks like we're getting more Zoom. So yeah, so check out our Zoom and go into that link. I think it's going to be a better bet for today. So, okay, back to our discussion. So patellofemoral pain syndrome can happen a lot from repetitive running, jumping, even going up and down stairs for prolonged periods of time, sustained kneeling, sustained squatting. I see it a lot in my practice with people that increase their volume of whatever they're doing. So if they're running and they're running 5K for months and months and months, there's no issues. And then they increase their volume to 10K or a little bit more. And then they start noticing all this inflammation in their knee. They start noticing pain. It starts off typically gradually and it increases from there. And sorry, I'm just accepting more Instagram. So try to go on Zoom, guys. Find our last post and try to go on Zoom. So we find a lot of issues with the knee with that. I find a lot with runners. I mean, myself, I treat a lot of Olympic weightlifters and powerlifters. So I see that whenever their volume increases or their program changes a little bit, or if they're not doing any recovery. So if they're training like 6-week programs and they don't take a week off or do active recovery, then I find that can compile and then they can develop these knee issues. Yeah, so any sport really, like I know squatting, jumping, running, going up and down, inclines and things like that are very common when you look at sports. So a lot of sports. I've had it before when I was younger. I was in kickboxing and karate and played basketball. So when you talk about sustained squatting, posture, jumping, running, that kind of stuff, I was abusing my body. And, I was probably a little bit heavier than I should have been at that time. So I developed a lot of knee issues. And that's how I actually ended up wanting to become a physio, is I spent a lot of time with my physiotherapist and realized that that was a profession for me because I was getting better and I noticed a lot of improvements in my activities as well, my performance, and had a good time during physio. So yeah, so I got some stats here as well. I looked up an article, which if you do want, I can give you a link to it or send you a copy of it. And it talks about hip abductor strength in individuals with patellofemoral pain. So I found this pretty interesting. Most common, the knee pain or patellofemoral pain is the most common running overuse injury. So they figure it's about 37.4% of knee injuries in running. So pretty common with that statistic. And it can change a bit too. So different studies might say different things, but it would try to indicate it's pretty high, it's significant. And then 80% of people with patellofemoral pain reported pain at a 5-year follow-up. So pain in some context, and they used a 0 to 10 pain rating scale. And it's pretty shocking that 80% of people still had the pain after 5 years. So it's showing that it's recurring. And if you don't do anything about it, don't resolve the issue, then it's going to likely come back or just stick around. And 74% reduced to their physical activity level due to the pain. So as a physio, as like a health advocate, an activity advocate, we want people to stay active. So if they're reducing their activity due to pain, that's something that is not good, and we need to resolve that. So that's where yesterday I did that little flow chart of active or acute pain. So if they just had the injury, just started noticing the pain, then you want to manage their pain pretty aggressively. If they've had it for several months, then yes, you still want to do pain management, but you can get into the rest of treatment as well. So you're not worried about, progressing the injury. So if it's acute and you get too aggressive, you can make that inflammation or inflammatory response a lot worse and cause further injury. If it's chronic, if it's been months and months, then you're likely not going to do any worse to it. It's just if it flares up, then the patient will tell you and say, hey, it's hurting a little bit more, feels a bit hotter, and we need to adjust activity. They might know their injury a little bit better because they've dealt with it for months. So they're probably thinking, hey, okay, I know what makes it worse. I know what makes it better. Someone who's a bit more acute with this or just started noticing the pain, they don't know too much about it, right? So their pain's pretty low and they don't know, what's going to make it worse or better. So those are some interesting statistics. So this study looked at neuromuscular components and strength components of hip abductors. So the gluteus medius, to the one that's always talked about with this issue, and improvements in pain. So they found quite a few interesting results. So I believe the programs, it was a systematic review. So it was 4 to 6 weeks of programming for hip abductor strengthening. And it showed 80 to 90% reduction in pain, which is a huge, huge deal. Like lots of research for for our profession, there's always stipulations at the end saying, well, we still need further research in these kind of fields, but it's a good initial study, especially being a systematic review. So looking at quite a few studies, quite a few different athletes, different activity levels. So it's pretty interesting to see that there was that big of a reduction in pain. So yeah, there was a difference. There was a significant difference, and it's worth looking at. So they didn't specify exactly what exercises they did for the hip strengthening or hip abductor strengthening. So in today's lecture, or whatever you want to call it, rehab series, we're going to do a few different exercises targeted at hip abduction strength. So some that might be a little bit easier than others, and some that are a little bit more difficult because we want to challenge people. So if you just had this injury and it's pretty lit up or fired up, you want to take it easy. You don't want to go too hard on any of these exercises. So what you want to do is start gradually and increase as you go. And I'll kind of label which one's easier, which one's harder. And then we're going to do the screen sharing here again to illustrate one more thing. So you have, and I'm going to flip the screen here. You can wonderful view of our laundry room there. So we have the Q angle of the hip. This is often discussed. A lot of argument on this as well. Some people say this causes patellofemoral pain issues. Some people say it doesn't. What I look at someone mechanically. So if one side's significantly different than the other, then okay, maybe there is a relation. And if you fix someone's mechanics, so improve this angle or improve whatever you're looking at, and there's improvement in pain symptoms, then yes, that's what you want to chase. So that's as easy as that. Whatever works, just keep doing it. So you look at females here. So the angle is from the top of the hip area, so the ASIS into that patellar region. This isn't typically kind of comes up from here all the way down into the center of the knee. So what all this is going to show is females have a bigger Q angle than males. So if you look at the left here, larger angle there, kind of going in. So if you wanted to think about knock knees, and then males, more bow-legged, so they're a bit more straight. Both can develop issues, but patellofemoral pain syndrome is typically more common in females. So they think one reason could be that increased Q angle. So you have this increased Q angle, you have a lot more pressure on that outside of the patella, right? So in this area here, you have a little bit more force transmission through that area since you're not in an ideal mechanical position. So that's just to illustrate Q angle very plain and simple. We don't want to get too much into it because there is argument of whether this makes a difference or not. There's one study that I looked at, systematic review, that targeted hip abduction, so try to fix that Q angle, and it did show improvements as well for patellofemoral pain or knee pain. So it's quite interesting. So I look at those articles also with a grain of salt and trial those things in the programming that I do with patients and kind of measure response from there. So if you look at a runner here, you have two runners here. You have one that's running has a neutral hip, so it's pretty level here. And then you have a hip drop. So that hip abductor stabilizes that hip. So if this one on the right had stronger hips or gluteus medius muscles, then you would have a level line, a straight line. So when I flip over to me now, sorry again, Instagram, if we get kicked out, there's been some live issues. So yes, it's been a bit difficult last couple of days, so it keeps kicking us out. It's not my problem or a Wi-Fi problem. It's just, yeah, something going on with Instagram. So if you look at that Q angle, so if you can see me from here, let's see here. So you can see my legs here. And I'm going to lower this down so you can see a little bit better. So you have the Q angle. So kind of coming from my hips here all the way into the center of the knee. So my angle, not too bad, right? So my knees aren't too bowed in, or sorry, they're not knock knees like that, and they're not too bowed out, right? So my knees are a little bit straighter, so not showing off, but I don't have too many knee issues. So if you're female, for instance, wider hips, you're going to have a larger Q angle. So your legs are going to be kind of like knock knees like that, not straight. right? So what we're talking about the Q angle is if you're like this, we want to essentially straighten out your knees so you're a little bit wider, right? So when you looked at that runner from behind, let's say my left hip abductors are weak. When I stand on one leg, what would happen is my right hip would drop a little bit, right? So if that hip, this side was a bit stronger, it would level out my hips. So what we're saying is when you're in single stance, so if I'm running and jumping, or if I'm walking, when you're in single stance, that's when that muscle on the opposite side, on that same side, keeps the other side level, right? So whenever you're doing jumping, running, things like that, if you have a stable hips, then your knees are going to be stable as well. That's the thought. So that's why we focus on strengthening the hips as well. We don't always just look at the knees. So if you think of patellofemoral issues as a vastus lateralis or a quadricep issue, and just focus on the quadriceps, then you might not notice any improvement. So if it's not a quadricep issue or a knee tracking issue, and it's more of an issue in the hips, then you're not going to have the results that you want to see. So that's a couple things. If there's any questions, you guys can post on that. Yeah, so that's the simplest way to think of a Q angle. Men typically have not as wide hips, so you have straighter legs or bowed legs. Females a little bit wider hips, so they have not knees, right? So you have more pressure on the outside of that kneecap, and that's what could cause the patellofemoral pain. So I can, sorry you guys got like a terrible view of my legs. They're pretty patchy. So any questions on Zoom or on Instagram? You can type in the chat area. So if Instagram has any questions, I know there's some connection issues, so there's typically more people that attend these, but it's kicked out. Someone said you forgot to shave. I see. Yes, I did not shave my legs for today. I thought it would be okay to show them as is. They're pretty patchy though, so I guess parts of them are pretty smooth. Any questions on chat, or if someone disagrees with something I said? And again, like I'm not trying to be vague. I'm just trying to also, think about other physios may have different ways of explaining this, and still trying to give credibility to everyone. So I might treat a certain way, but that doesn't mean it's the right way. But I just look at mechanically what's going on. So whether it's truly a quadricep issue or is it a hip issue? And usually by cueing the right muscle. So if it is a hip issue, you do a couple exercises for cueing the gluteus medius or the hip abductors, and then run or do the activity that's bothering you, right? So if it's jumping that's bothering you, you cue the muscle group that you think might be at fault or underactivated, cue it, make it activate, and then do the activity and then see what happens. If there's significant change, then hey, that's the issue and we need to focus more on it. Yeah, that's how I kind of treat. So I'm more of like a function type of physio. So I'll assess somebody, try something out, and then reassess. And that's usually that's always within the same treatment. So then exactly what is making a difference rather than receiving all these other things. So if you do exercise for everywhere, like your hip, your knee, your ankle, it's often hard to determine what is causing the benefit. If you're benefiting off all that, that's great. But you also want to figure out, what structure is causing the actual issue itself, right? So if you're an athlete increasing volume and squatting, is it the posture that's affecting it? Like, is it that knee position that is affecting the injury or causing the injury? Or is it just too much volume? Or is it just way too much activity? Because that can happen as well. You can have the great mechanics, perfect alignment, everything looks anatomically correct. But if you just overtrain, no matter who you are, you're going to get some sort of injury. And if you're not managing it properly and doing your recovery, like your ice, your stretching, your rest, then it's just going to compile and get worse. I've had a few athletes like that in which, and well, not even athletes, a couple of them were high level athletes, and a couple were people that just went to the gym, 3 to 4 times a week, and they just progress their activity too much and too fast. So they increase volume way faster than they should have. And that resulted in injury, right? So you can have an area that's as stable and as strong as you want, but you can still get injured. And that's the thing. A lot of people say, I want to strengthen this so I don't get injured. And I tell, yes, we'll reduce the chance of injury by strengthening and stabilizing the area. But at the same time, you can always be at risk for injury. It's just, are you going to take the proper precautions and do your prehab, right? And then if you do get injured, then do all your management techniques and make sure you're getting better in an efficient way. So like me, for example, I always use myself as an example. The times I've been injured and haven't listened to my own advice would be months and months of pain. But when I do, it'll be like a week, and then I can get back into my activity a little bit faster. So these days, like I have some patellar issues. I get a lot of swelling in my knee when I do heavy squats or train a little bit more. So I'm icing like, I don't know, 2 to 3 times a day. So even when I was going to the club that I train at, I would put ice packs on my knees sometimes right after training. So I'll be sitting there putting ice on and showing athletes and active individuals, hey, I do a lot of the stuff I prescribe. So if you've had knee pain, I assume many people have had knee pain in the past. So sorry for all the people that are joining on Instagram. It kicks us out once in a while. So since yesterday, there's been some volume issues with Instagram. So Instagram Live kicks us out repetitively. So usually we're cooler and the number on the top shows like 1,000 people. So yeah, so sorry about that. So if it kicks us out, just look at our last post on Facebook or on Instagram, and then you can go to the Zoom link, and then you can just join the Zoom group, which we have quite a few people on right now. Anything that you guys wanted to ask before I move on? Hopefully that made sense. I know that was a little bit all over the place, but hopefully that made a bit of sense. The challenge is always making things not complicated with injury. So yes, someone's glad to be my only friend and feel special and yet to be kicked out. It's not even like individual people being kicked out. It's just like our live feed just cuts out and ends, and it says live feed has ended, and I just restart. So I guess we are a little bit lucky now that it's been lasting longer than 10 minutes. So yes, just in case if it does kick us out, just go on Zoom and we're good. So everyone on Zoom, does that make sense? I'm gonna randomly unmute people and ask them. How was that explanation, Brooke?
That was wonderful, Sunny.
Okay, good. And I'm gonna mute you. Sorry, I feel rude. Okay. Any questions, Jenna?
No, that was good. Thanks.
I know sometimes I speak like all over the place, but I don't speak gooder sometimes.
But neither does Brooke, so that's okay.
English is my 14th language, so sometimes I make mistakes. It's not. It's my first or second, maybe second. And Kirsten, everything okay with that?
Yeah, big fan of your work.
Okay, this is great. Hopefully I'm not an out of practice physio. So, I mean, the big thing is the take-home message is mechanically see how someone is built. You can go left and right differences, and you can look at this doesn't look right, that doesn't look like, but sometimes it doesn't matter. Left to right, there's always differences. Just like the shoulders might be different positions, the knees and the hips can be the same. So you got to think, hey, okay, let's see how far, like if it's a big deviation, let's try to fix it. If it's a little bit, let's try to cue things, make them work right. And then you'll truly know it's right when you actually reassess and see how it's doing, right? So if you're completely wrong, then it's like, okay, the pain's worse or nothing's changed. And sometimes it'll be a very gradual difference. It's not going to be like I have an 8 out of 10 pain in my knee and I fix certain things and now I have 0. It's going to be like I have an 8 out of 10 pain. Let's adjust some technique, and then I have like maybe a 7 or a 6, and then okay, this is the right track. You're not going to you can't bypass the healing process too much. There's still going to be natural recovery. There's still going to be time that's needed to get better. You just got to really educate people on, okay, it hurts. It's a 3 out of 10. Okay, maybe continue doing what you're doing. As you continue doing that activity, it's a 4 or 5, then you stop. Then you won't need to actually take time off that activity and only get back to it when it's relatively pain-free. Like if it's low pain, go back to that activity. So if you're a runner and you're running and throughout the week, you notice, okay, I started off with a 2, then a 3, then a 4. Okay, then maybe just take it easy for the rest of that week and get back to it the next week. And if you start with a 3, continue going. And again, if it goes up, just stop. And then after that, we can give you more advice on how to get back to running or that activity. So knees take a lot of stress, right? So if your whole lower extremity and core isn't strong, then it's going to add up, right? So your ankles, for instance, as you walk, take quite a bit of impact, then less impact through the knee, and then less impact through the hip. But each joint is still transmitting load. So if one joint's weak, then you can have issues, right? So if you have knock knees, that can also affect your ankles, right? So then you can have more inversion in your ankles, so then you can have ankle issues. So whatever you do to one joint, you got to figure out what is it going to do to the other joint. And is there a way you could introduce exercise to fix everything, right? So we want to be efficient with activity. I don't like doing, sitting down and doing banded things all the time. I like to get up. Humans are meant to be standing. We're meant to resist gravity. So we want to do most of the activity in a standing position. So I'm not the one that gives a lot of bed exercises. I try to throw those out as fast as possible. So if someone comes in with significant pain or post-surgical, then yes, I'll do, quads over roll and other exercises like leg raises. But since we're meant to resist gravity in our weight, those get easy pretty quick. Those aren't going to develop strength. That's just cueing muscles to work, right? So we're trying to help that neuromuscular control. Here's your quadricep. Here's how to use it. Okay, now let's get up and let's do the same thing in weight bearing or standing. Same thing with the gluteus medius. We could do clamshells all the time, but nothing's going to be making a huge difference unless you get on your feet. So that kind of gets us into some of our exercise we're going to start with. So clamshells being the first one, which I'll show. A lot of you probably already know how to do this, but I'm still going to show it to you. Yeah, so that's that position. That should be good. And then I'm going to point this down just like that. Okay, so all right, I think everyone, actually, Instagram, put this a little bit. Good, so clamshells, we've all heard of this one at one point or the other, or, most of us have. As physios, we have for sure. So what I do is I'm side laying, and I always tell patients or clients to keep their feet together. Those are going to be fixed. You're going to be hinging in this area. You're not going to be lifting the feet up. I see a lot of that. And what you're going to do is you're going to keep your hips stacked. So you want to keep your hips so that this area should be pointing straight up. So if I was to put a bar through you, you wouldn't be rolling backwards and you wouldn't be rolling forward. Right? We roll too far back, you're using a lot of glute max. You roll too far forward, you're using too much hip flexor and other areas. So what you want to do is stay stacked and just open up like this and back down. So a lot of people try to lift as high as they can and they think that's going to be making a difference, but no, we need to just keep that hip flat and not rolling back, not rolling forward, and coming up and down just like this. So coming up, holding for a couple seconds, and then down slow. Up, hold for a couple seconds, down slow. And continue doing that. So if that's easy, grab some TheraBand and wrap it around your knees, right? So you can tie it around your knees, and then now, okay, you got some resistance, which I'll actually grab because I'll be needing it anyways. So to make it a bit harder, and let's say this is warm up. So let's just say this is warm up exercise 1. So I want everyone to try things as we do today. and see how it goes. So whether you're a runner, fighter, Olympic lifter, doesn't matter. Try to do all these things first as a warm-up and then do your activity. So if you ever had knee pain, do these things and see if it makes a difference. It should make some sort of difference. Not saying everyone has patellofemoral pain syndrome. You could have a meniscus issue or osteoarthritis or a whole list or a whole host of injuries. So try this out and see how it goes. It should be safe for everyone. So I'm trying to pick exercises that aren't going to kill people. So coming down, so up and down just like this. Up and down just like that. So let's say, I usually say do 3 sets of 7 to 10 reps. So whatever you can do. So if you could do 10, do 10. And I always tell people your sets, so the last couple reps of every set should be very difficult to do, but they're doable. So if it's easy to do 10, then you need to progress either how many reps you do, or make this tighter, or grab a harder band. So that's exercise, or let's say warm up 1. So let's just, for example, you're a runner, you got knee pain, you think it's patellofemoral pain syndrome, try these things out. So the next one, and what you could do, I'll do this right there. What you're gonna do is you're gonna do some squats. So I just have a dowel. Everyone should have something like this at home. I like the dowel because it keeps my back straight. So sometimes when people squat, they don't have their back straight. So I like to make all the exercises neutral. So the best way to do that is to use a dowel, just like you had a barbell on your back. So feet shoulder width-ish apart. Toes can be pointing a little bit out if you want. And the big thing here is the knees stay in line with the big toes, right? So I have a force going inwards, and I'm trying to resist that by pushing my knees out. Helps activate the glutes a bit, and then come down and back up, and then down and back up. So just doing same thing, right? So sets of 3 sets of 7 to 10 reps, right? So going up and down, getting a good burn in your muscles. So where you want to feel it is you'll feel a little bit in the knees, but you also want to feel it kind of in the glutes here. So on the sides. That could be warm up number 2. And now to progress things a little bit, we can drop this a little bit lower around the ankles. And now what you're going to do is you're going to come to the side. So you're going to step to the side, right? So you could say I'm in a quarter squat position, half squat being knees and legs at 90 degrees. So quarter squat, my feet are pointing straight. And what I'm doing is just taking a step to the side with control and back. Stepping to the side and back. And then going the other way. So you can do 10 steps to the right, 10 steps to the left. And what you're going to do is you're going to be feeling a bit of a burn in your butt, in your glute area, right? So I keep doing this until I get burnt out, I get tired, so fatigue. So I don't usually tell clients or patients to put a timer on. I just tell them to do it until they're tired and they can't do it anymore with good posture. So good posture being they can't maintain that quarter squat, and then they start leaning a lot with their upper body. That would be cheating pattern. So yeah, that's another good exercise. So if you do the clamshells first, then you do some squats at the band around the knees, and then doing some sidestepping. That's pretty good. You could also, if you want to start working on the core as well, you could do, what's a little bit more difficult is you could do a side plank, right? So doing a side plank with hip abduction. So just doing that kind of motion until you get tired. That works on both sides, works on your core, works on your back. If that's too hard, you could bend one knee, go into a plank, going up and down like that. So very, very good progressions if you need to do it. Yeah, so that's a good program, you could call it. So The real strengthening happens when you're doing your activity that you're interested in. So I'm just gonna move that up here. I don't think there's any questions on Instagram yet. Okay, so let's say, for example, I'm treating a lifter, an Olympic lifter that has knee pain. And I'll show this, and I've shown this program to quite a few lifters with this issue. What I'll do is I'll show them this warm-up program, right? So just using a band and using that as a warm-up before they start lifting. So the thing is, this is a cueing program. So I just tell them, hey, we're trying to make certain muscles work a little bit harder. That way, when you do your activity, you're using them a little bit more, and that's when these strength happens. So if I do sidestepping, so to speak, with a band, I don't think you're going to be strengthening that much. You're just doing that neuromuscular control. You're firing off muscles that might need to be fired off during your activity that aren't being utilized. So if your glutes aren't being utilized, it might not mean that they're weak. They just need to be, worked a bit. They need to be told to activate. So what I do is I'll say, hey, do all these exercises, and then, okay, now do your lifts. And I find that a lot of people will notice a lot less pain. So, and when you're capable of doing a 220 kilo squatting with the band around the knees with a barbell isn't very difficult, right? But when you're cueing the right muscles and then you start lifting heavy, then you actually increase the strength of the muscle. So that'd be a good warm up for everyone to try. Any questions on either platforms, Zoom or Instagram? And then I'll make a schedule for next week as well. We want people to ask, like if you have certain issues or questions. I know someone has mentioned SI joint problems. Someone has talked about trying to get a pelvic floor specialist to do a chat. So I'm trying to link up with other clinics to do that. I've sent a couple messages out. And then there's been a couple of requests for sciatica. So we're going to be doing that as well. So if there's anything that you guys want cleared up or other topics, anything at all, we're likely going to be in this for quite some time yet. It would be good to get a whole huge list of topics, and we can, make a 2 or 3 week schedule. And then I'll do my TMJ next week, which would be interesting. I'll need a model though, so I'll have to have somebody here. That way we can actually show you opening, closing, all the issues that happen with the jaw. So can you talk a bit about knee tracking, any exercise that you like to target that? So knee tracking, so the patella itself does move kind of in a pattern like that. So as you flex, it moves down and out. So I'm referring to, I guess, my right knee. And then extension would be the opposite way. So tracking issues usually have a bit more, I find, more pain like immediately medial or lateral to the patella, and then you get like clicking and popping, and a lot of people will categorize tracking issues within patellofemoral pain because it is a patellofemoral issue, so they kind of just put it in the same umbrella. Exercise wise for tracking, so it depends if it's tracking, like, so when you do your assessment technique, you'll actually assess the patella and see its movement. So if it's moving too far medially, then okay, we might need to strengthen laterally to keep that in place. Or if it's too far, if it's tracking too far laterally, like it's too lax, I guess you could say, you want to target more of the inside musculature. So like VMO, again, huge disagreement with an argument about VMO and vastus lateralis and things like that. But again, I just say, okay, if it's a tracking issue laterally, let's do this. If it's a tracking issue medially, let's do that. I'm just looking at another question. Can you recommend a knee brace that doesn't make you lose circulation to your calves during running? Okay, we'll answer that as well. So if we're looking at, I'm just trying to figure out how to rig this up. So tracking, again, if it's like a medially displaced patella, then yes, do everything we just did, working on hip abductors as well. And then to kind of get that patella to be a little bit more lateral. And it's like millimeters of difference. It's not as much as people think. Clicking and popping could be common with tracking issues. So yeah, let me just undo this and then we'll try a couple of things. So if the knee isn't tracking laterally, then you can do everything we just talked about. If it's medial, then you can work on some DMO strengthening or adductor strengthening. So what you could do is just do the opposite, right? So you could grab a ball. Let me grab a ball quickly. And do squats with the ball between the knees, right? So doing this, let me go to here. Right, so tracking. So trying to keep the knees in line with the big toe. A slightly larger ball will be better for me. But now doing a squat while keeping the ball held between the knees just like that. That's pretty straightforward. What you could do to make it a bit more difficult, I like lunges a lot, so if I point this way, point that way, we have our wonderful Tydex rig here. So if I'm doing lunges, this is my right knee, my left knee. I'll just bias the medial quads by doing, I think everyone can see this, so bands coming outwards like this, and now doing a lunge while keeping my knee in line with my big toe. Coming down and up, I need to take a step back because my knee is going over my toe. Coming down and back up, just like this. So that is creating more bias medially. So hopefully that answers that. I can get into a lot more detail, I guess, but we could talk a long time about that. But determine where the issue is, the weakness, so is it medial or lateral, and then you can just bias certain muscle groups pretty easily. In terms of the, sorry, I scratched my leg. In terms of the knee brace question, specific knee braces, I don't really use knee braces or recommend them unless there's a ligamentous or instability issue. So what it sounds like is it doesn't make you lose circulation. So it might just be too tight. So if it's adjustable, loosen it up. If it's a neoprene sleeve, then well, I guess you can't really adjust it. I would just try ones that are adjustable, to be honest, because the brace itself isn't doing much. It just typically gives a little bit of support. It makes you feel a little bit more comfortable so you can do your activity. I would try to wean off of it as you can, but it all depends on why you're using it. Like if it's an instability in the knee, then yes, you need something to stabilize it a bit. So I would just try to use it a little bit less, wean off of it, right? So if halfway through the run, you're losing circulation, just take it off and just do half of your run with the brace and half without. And if that's the case, then good. You want to wean off of it as much as you can because you don't want, to weaken the knee further. But it depends why you're using it in the first place. Braces, I only recommend if, again, someone doesn't feel stable, like their knee gives out, then I recommend it. But even then, I say only use it when you need it. So try to wean off of it as you can, as you feel comfortable. So hopefully that answers it. Yeah, and you can also message me if you have more questions. Does that answer that question, Kirsten? Or sorry, Kirsten? Hopefully it does. Thumbs up on this side for the knee brace, that's good. Yeah, that's good. So just play around. Like as a physio, you're always gonna be like, yeah, I need to nail this and I need to figure out exactly what's wrong. But I often tell people, okay, like know the structure that's an issue. Is it the kneecap itself? Is it the meniscus? Is it a ligament? And once you narrow that down, your treatment program is going to be appropriate no matter what. If it's a strength issue and you're strengthening, then you're going to be solving the problem, so to speak. And what you want to do is test and retest. So just like I know for me, it was Jeff Bostick that used the term patient response-based feedback. And that was like the single most important thing that I learned. And it's so obvious, right? To try something and retest in the same session, and then there's your biggest change. Like that's what's going to tell you if you're on the right track or not. And I use that when we're open or even on telehealth. Like I'll reuse that all the time. Like, okay, let's try this. Does it feel better? No. Okay, let's switch it up. Does it feel better now? Yeah. Okay, let's do that. So it's all about testing and retesting. So if it's a patellar tracking issue, try a different bias for lunges, and then retest and see how it goes. And if you're on the right track, it's going to feel better. And I'll open the floor for a few more questions. We got like another few minutes, so we can open up the floor to any questions you guys have. We're not as cool on Instagram today because of all the issues. I was hoping to see 1,000 people attending. That's my goal. That'd be a good PR. I'm definitely not doing that in my lifting because there's no facility to lift at, unfortunately. I have this clinic, I guess. Yeah, a couple more minutes. And then, so next week we're going to do TMJ issues, likely Wednesday or Thursday. And then we'll do some SI joints, some sciatica. I'll try to get a women's health or pelvic floor specialist as well to join in and see. And then we're trying to link up with some clinics in BC and Toronto as well. So trying to do that as well. So other than that, everyone have a good weekend and try to be safe, try to be sane, be nice to one another, and make sure you ask us more questions and give us more tips and get more people to attend these things. It's fun to do, like it keeps us sane. Yes, no problem. Thank you for attending. Yeah, and then just make sure you let us know if you have any concerns or questions, and we like doing this stuff, and it helps us get by too, right? This is a tough time for us as a team and for me as well. And this really helps keep me going as a physio and keeps me engaged, keeps me busy so I don't get bad habits. Yeah, so make sure you guys keep attending, and if there's ways to improve this, let us know, because we don't want to make this boring for anybody. Yeah, and we'll kind of gear it towards who's attending. So if there's more physios or students or general public that are attending, then we can kind of shift it a little bit. All right, guys, thanks a lot. Have fun, stay classy, and we'll see you next week.